Well, hello to everyone. Thank you for being here. The people is connected right now and who is going to see the record later. Welcome to the All About Pectus Excavatum Masterclass. We are really excited to be here with you today. My name is Rocío Alcántara and I am the International Patient Coordinator here at Clínica Pectus. My job is to guide patients and families from all over the world through their journey to a successful correction from the pectus. Before we begin, I want to share a little bit about who we are in Clínica Pectus. We are a global reference center located in Buenos Aires, Argentina, with over 15 years of experience and a medical team dedicated to the treatment of chest wall deformities. I am very proud to be part of an excellent team with more of 20 professionals, which include pediatric and adult surgeons, anesthesiologists, physiotherapists, specialized scrub nurses, communication team, and our dedicated administrative staff. Today, we are proud to be a leading center in the world for these pathologies, not only because we have the most pioneering and advanced technique, but also because we are a reference in scientific publication detailing the treatment we have performed of thousands of patients. Because of this, we welcome both patients and doctors from all over the world to our clinic. We decided to host this masterclass because of the many questions we received from our international patients and to clear up a little bit all the misinformation that we often see in social media. Our goal today is for you to empower with resources and information wherever you're seeking information from yourself, for a family, for a friend who is dealing with Pectus Excavatum. And we want you to live today fully informed and ready to have the right conversations with your doctor or visiting us here in Argentina. A quick note before we start, as you can see, it's all muted because of the order and for avoid background noise. If you have questions, please text or write it down in the Google Meet chat. We will answer in the end, and the doctors also answer all the questions that you just write it down in the Google form that I shared with you. Join us today. We have Dr. Facundo Giacosa. Thank you very much for being here. And now it is an honor to introduce your host for tonight, the director of Clínica Pectus, an executive board member of Chest Wall International Group, and a true pioneer in modern chest wall surgeries. Please welcome Dr. Gastón Bellía Munzón. How are you today?
Hello, thank you to all. It's a pleasure to be here. Thank you to be there. We can start to talk about this pathology. Maybe the Dr. Giacosa is start the class.
Okay, thank you very much. We're very excited to be here with you from Argentina. So we start with a little bit of what we are going to present today. Okay?
Yes, we have the first question, a basic one and really important one, actually, for all of us that we are not doctors. Are all thoracic malformations the same? Because we see a lot of different shapes of the chest wall, and maybe you can explain a little bit to us.
Yeah, perfect. In thoracic pathology, we see different type of chest, but we can say that the most common chests are maybe two types. The first type is what we are seeing in this image. This is a Pectus Excavatum. This is commonly known as pigeon chest. And as you can see in this image, it's commonly a protrusion of the anterior chest wall. Okay, so as we have different types of Pectus Excavatum patients. The most common are shown in these images, which is what we call a chondrogladular pectus. Okay, and as you can see in the image in the right, we have a 3D scan of these patients. Okay, these patients in Argentina are very common and different what is seen in other parts of the world are maybe 50% of the patients we treat in our clinic, okay? So it's a very common pathology. On the other hand, we have the other most common pathology, which is Pectus Excavatum, known as the sunken chest. And also, what we can see in this image is, on the other hand, different to the Pectus Carinatum patients, we see like a hole in the chest. The chest is sunken in the anterior wall, okay? This is a very common also pathology. Maybe here in Argentina also we have another 50% of the patients having this pathology. So we have the Pectus Excavatum, which is also a very common pathology. Here in Argentina, as I was saying, we have more or less the same amount of Pectus Excavatum than Pectus Carinatum patients. And as we can see, and different from the other patients, we do not only have a 3D scan, but also a very common test we perform here in Argentina, which is an MRI, a cardiac MRI, showing the anatomy of these patients. Okay, we are going to talk about both of these pathologies, and we'll address your questions obviously later too. Okay, and a little aspect of this pathology are the complex cases. We have asymmetric, we have combined pectus, what we call mixed pectus, where one part of the thorax is carinated and one part of the thorax is excavated, okay? We see a lot of these patients too, as we are a clinic which is referral of other centers. And we're also going to talk a little bit about these patients later and their importance in this pathology too, okay? So we have the three type of pectus that we are going to talk about. Remember, the ones who are a protrusion of the anterior chest wall, the Pectus carinatum, the ones that are sunken, the Pectus excavatum, and pectus that combine both aspects of the pathology, a part that is excavated and a part that is carinated.
Thank you for the answer. Does the depth of the pectus determine how severe the case is? Because the common sense tells me yes, but I don't think so. Please explain to us.
When we talk about the Pectus excavatum, we have different morphologies of pectus, okay? Not every patient is the same. And as you will see afterwards, it's very important to determine which type of pectus we are seeing because every patient needs a different type of treatment. So these are the most common thoracic morphologies we see in Pectus excavatum. We have what we call the punch type, which is a depression of the lower part of the sternum. This is a patient we are seeing in our left. We also have in the center the Pectus excavatum, which are the flat chest. We also call it like plateau, which are not only they have a depression that maybe is mild, but they have a wide type of depression. And many times these patients are associated with anterior posterior lower anterior posterior diameters, okay? And this is also important to notice. And finally, we have one last type of patient, which is called the Great Canyon type of patients. We have many patients even have a complete depression of all the sternum, okay? The most common one is the punch type. Maybe it's 50% of the cases, okay? Second, the Grand Canyon type, which is 40% of the cases. And finally, the flat chest that goes around 10% of the patients, okay? This is very important. We do not only see the sternum, okay, but we need to rely on many aspects of the thorax, okay? When the sternum is depressed, also the ribs and all the cage has a malformation. So it is important to see the whole picture. As you can see, continue with this idea, here we have the 3D reconstruction of a CT scan, okay? This is a regular type of thorax, and you can see very clearly the difference between this type of thorax and a pectus type, okay? not only the sternum, as we were saying, is depressed, but all the ribs and the cage as a whole are there's a malformation, okay? And we can clearly see this pectus is associated with this type of patient. So it's, for us, it's very common sense, I would say, that this is not aesthetic malformation, okay? It needs a repair, and most of the times they will need a surgery. It is very important, okay? But why do we need a surgery for these patients? As we were saying, this is not aesthetic, okay? This has a very important physical impact in many patients, okay? 80% of the patients we have studied in our own clinic have a heart compression, okay? Many seem to have fatigue and tachycardia. They also have problems with their postures, okay? They have protracted shoulders. They have forward spine curvature with kyphosis. And because of all of these, it is important to treat these patients, okay? Different patients will have different symptoms and different types of compression, as we are going to see, okay? But it's very important to have these thoughts in mind, okay? And of course, our group obviously see the psychological impact also of these patients, okay? There are many studies that show low self-esteem and anxiety, body image distress, social avoidance. These patients don't want to get their shirts off when they go to a pool, for example. They don't want to go to a beach. They have many issues with their own bodies. And this is very important also to notice, because many of our patients suffer bullying, okay, and stress is a very important issue, not only in adolescent patients who are undergoing different circumstances that are important to notice. Their whole psychology is it's important, but also we have a lot of adult patients who carry this along their lives, and they come to us with that concern, okay? And it is very important for us to give some response to those patients.
When it happens, when it pectus appear, can an adult have it? Regarding the previous slide.
Maybe the symptoms appears when the pectus appears in some patients. If the patient is athletic patients, maybe when the patient grew and the pectus appears or worse, maybe in that situation the patients say, I'm not stay in the same way. I'm start with the symptoms. And in the other patients, when the patient is grew maybe than 18 years old, when the chest is very rigid, start with the symptoms later. You know, it's different in different patients.
Okay.
In the young patients, 5, 6, 7 years old, there aren't symptoms. It's only the examination, and they have pectus, but nothing more. In that situation, maybe we start early with no surgical treatment. It's about vacuum belt. It's not the topic in this class, but it's important, you know, if the patient is very young, is very soft, and they have pectus, is a good time to start non-surgical treatment to prevent the worst when the pectus when the patient has 13 or 14 years old.
Okay, doctor, that's really clear. But how many symptoms do I need to have for surgery, or how do you know when to operate a patient?
The most important thing at this time is the cardiac compression. Dr. Facundo say 80% of our patients of our series has cardiac compression. This is our classification. It's a first classification about cardiac compression. This type 0 is without cardiac compression. They have pectus, but it's not compressed the heart. The type 1 is when the sternum compress the right ventricle, the free wall of the right ventricle, and the type 2 is right ventricle and EV group. As you can see here in down of the screen.
The gray circle, that shape is the heart, right?
Yes. In the middle of the chest is the heart. In the left side, without compress, in the middle is only right ventricle compressed, is type 1, and on the right to the screen is type 2. Is
Okay.
right ventricle and EV group. This is the worst compress.
Yeah.
And this is this is a video and 3D reconstruction on MRI of one of our patients is type 2 cardiac compress. The right side of the heart is very flat, as you can see at the video. It's incredible.
Amazing.
And the other indications for the surgery, the first is cardiac compression and dysfunction of the ventricle. The most common is right ventricle dysfunction, but in some patients had right biventricle dysfunction, right and left. The other indication is fatigue and exercise intolerance, but in most of the patients, it's not about lung, it's about cardiac compression. It's the same situation. Maybe the cardiac compression produce arrhythmia, tachycardia, or maybe fatigue and exercise intolerance. And it's the same problem. And the other problem is a psychosocial impact, is the other indication for treatment this pathology.
Yeah, I can see that in the picture. There is a child with a t-shirt on the beach because of the Dr. Jacosa was saying about the shame or the bullying. Yeah.
Yes, it's common and it's important for the patient and for the family.
Of course. So we read a lot about the Haller index. Every patient in social media say, I have a Haller index of that point. Do I need surgery? Is the only metric that matters. What is the Haller index?
We don't care the Haller index.
No.
It's not good. Because
really?
this is a Haller index. It's the transverse diameter divide anterior-posterior diameter. It's only that. And it's not the same in all the thorax. The Pectus Excavatum is most than sternum depressed or is all the chest wall is malformation. You know, the better index is the correction index. Is this index. This index is the difference between the anterior wall or normal wall and depressed wall. You know, it's an percentage. And it's clear the difference. Under 10% is not pectus. More than 10, the patient has pectus. More than 20, the patient needs correction of the pathology. And the difference in the next, this is very clear, or maybe for us. In the left side is a normal chest, is a regular chest, and the Haller index is 2.4, and correction index is 0, because the sternum is in the same line, in the same anterior rib line, you know. And in the other side, on the right on the screen, is punch. Haller index is 3.4, and correction index is 29. The other thorax is a flat chest. The Haller index is worse, is 5.8, and the correction index is 33. And the last is Grand Canyon, as you can see at the image, the sternum is in the middle of the chest. This is worst chest of all, and the Haller index is 5.1. It's better than flat chest, but the correction index is 55%. Is worse than all. You know, for us, correction index is better to the diagnosis of this pathology. Haller index, maybe some patient has normal Haller index with Pectus excavatum, and some patients with Pectus excavatum has Haller index maybe 2.8. If I decide the treatment only for Haller index, is not good idea for the patients and for the health of the patients. You know?
Yes, I can see that. So what indices do you use to plan the surgery? Because I think you have your own.
Yes, for the surgery, we observe or we see all the patients first. Second, we see the MRI to diagnose the anatomy of the heart compress. And then we perform the echocardiology stress. Is very important for us because the MRI is about cardiac compress and echocardiography is about function of the heart. It's different. In echocardiography, is the diagnosis is about cardiac. No, it's the dysfunction maybe in stress. You know, the most of the patients when they have cardiac compression, the echocardiography in stress diagnose the dysfunction of the right or left ventricle in the other things, you know. And then the anatomy of the patient is about CT scan, and we observe to prepare the surgery, the CT scan, and we use our index, the Titanic index and banana index. We describe and publish their index, and it's very useful to surgical planning. The Titanic index is maybe the next is the Titanic index is the percentage of the sternum behind the anterior costal line. If the patient has more than 60.5%, that patient needs more than 2 implants because the pathology is high, is all the chest. If the patient has maybe an example 70% of Titanic index and body mass index higher, the patient maybe needs 4 implants because it's very high and the Titanic index is worse. And the other index is about the shape of the sternum. This is the retroesternal angle or banana index. When the patient has more than 148.5 degrees, the shape of the sternum is like this, is like a banana. And this patient needs 2 implants in the tip of the sternum to put out, to put in anterior wall. For this reason, if the patient has, for example, 148 degrees and 70% of Titanic, the patient needs 3 implants, 2 cross in low chest and 1 horizontal in upper chest to total chest remodeling, you know? And this index is very useful for us to prepare the surgery.
Okay, that is really clarifying. And do you mention different, I don't know, I assume that you have different techniques for the surgery, and I read a lot in social media about that. What is the most effective approach today for the surgery?
There are different surgery for treatment of the thoracic malformation. It's not only excavatum pectus or mixed pectus or carinatum pectus. They are different. The first, it was resective surgery. The most common name is Ravage procedure.
Yes.
Start in 1949. And then in the history, the patient was problem about the growth of the chest. Maybe in 1916 appears the acute shame because the child doesn't grow, because the resection is the cause of that. And in this kind of surgery, we need anterior incision in the chest and resect the cartilage and maybe as you can see here, this is the rib and this is the cartilage.
Yes.
And this is the center of the growth of the chest. When in this kind of surgery, we cut this area, the thorax, it doesn't grow. And this is a problem about this surgery in young patients. And then the other problem is if they only treatment with this kind of surgery, the recurrence of the chest deformity is most common. And at this time, we use this kind of surgery combined with MRI, MIRPE, minimal invasive repair of pectus. It's not more a little resection, is hybrid surgery. And at this time, we use resection in hybrid surgery, not only ravage or only resection. You know?
Because if you perform only ravage, there is a risk to reoperate another surgery.
Yes, we have a lot of patients. We redo a surgery at 30, 35, or 40 years old. When that patient, it was operated at 15 years old, and then come with us, and 30 with symptoms and cardiac compress.
Oh.
It's very common at this time. And the other side is maybe the people know about Pectus Up. The Pectus Up is anterior incision of the chest and put the implants there, and is not pull.
External implant? What do you mean with external implant?
External implant, the incision is in the anterior wall of the chest and pull the implant outside the chest.
Oh.
Yes, yes, to bring down the sternum when the sternum is fixed to the external implant and pull up the sternum. This is maybe only for the lower malformation because it not produce the total chest remodeling. It's only in one area. When you put here the Pectus Up system, only repair this area of the chest, but not the upper chest. And the next, maybe.
So you cannot perform Pectus Up for the another two types of Pectus Excavatum, Great
Yes.
Canyon and flank chest.
It's not good. Maybe the results are good, but not very good because it's not performed the total chest remodeling with this kind of surgery.
Hmm.
It's good when the patient maybe it was operated with a sternotomy or other pathology. It's very difficult put inside the chest other implants. Is perform this kind of surgery for outside of the chest. It's only in the anterior wall, and we don't enter in the cavity, you know.
Okay.
The Nuss procedure it was the better of the kind of surgery. It was the revolution at 1998, and because why it was a revolution? Because the incision is lateral chest. They don't resect anything of the chest. The growth of the chest continue, and put one implant in the first behind the sternum, push the sternum to outside. And physical movement is better, push than pull. It's too easy, push everything, the car, when the car stop, you push, no pull. You know, physical movement is very higher to another, yes. It's very useful. And in that year, it was a revolution because all the world start to perform the Nuss procedure, and many patients, it was operated with this kind of surgery, and the results are very well. And then, when all of the patient it was operated, appears the problem at that technique. No, is normal. And the problem of the Nuss procedure was the risk of cardiac injury, the intercostal muscle tearing when the patient has a rigid thorax. They are bending manually because it's not prepared before the surgery. Is prepared.
In the operating room, you have to bend.
Yes, in the operating room. Incomplete or not total chest remodeling, incomplete thoracic remodeling, because in that time we use, or the world used only one implant in the deepest point of the chest, but it's not only the problem in that patient. And the pain is worse because when they put the chest in another position, there are a lot of microfracture and a lot of pressure. For this reason, this surgery is the pain is worse than the other with the resection. And there were the problem in this procedure in that time.
How many pain? How many more pain? More days in hospital or what? More
days, more medication, more days in the hospital, and start the movement later.
How many
Yes,
days?
and today everything is changing. And today is the revolution of the evolution. This time is a good time. Maybe 10 years ago, started changing the Nuss procedure. Maybe 10 or 15. We use the external elevation. We use external elevation in all of our patients. When the patient is in the OR, the second situation is external elevation. The first is cryoanalgesia, is to treatment the pain after the surgery is necessary. Then we talk about that. But the first is cryoanalgesia. The second stage in the OR is external elevation. It's very safety, the surgery. Maybe all the patients need one external elevation, and maybe other patients need 2 points to pull up the sternum. The third difference is 3D surgical planning. We use the custom-made implants to the patient about your CT scan, their CT scan. When the patient, we decide before the surgery how many implants the patient needed, and the custom manipulation is for individual patient, is for him only for the individual patient. Yes, if I need 3, in the OR I had 3 implants for these patients, and the other problem, they are the rotated or the movement of the implants, and we use 11 years ago, we start to use bridge, and the stabilizer is don't use never again. We use bridge and never bar displacement more maybe in the last 12 years.
I have a question about this. In Nuss procedure, traditional Nuss procedure, they put 1 bar?
Yes, in the first time, yes, and most of the surgeons at this time in the world today continue with 1 bar. In many centers start to 2 bars, and we use in more of our patients 3 bars. We don't use 1 bar anymore. 12 years ago, don't use one bar.
Okay.
Yes, and the other difference is the postoperative management. The pain is about cryo. Maybe in the next slide appears cryoanalgesia. Well, this is an example for no complete thoracic remodeling. You know, is in the left side is the patient. Maybe it was our patient in 2011. In that time, we used only 1 bar, and the right photograph is postoperative results. The patient are happy. We are happy in that time, and if you see the upper chest, is no remodeling. You know,
Because of the hole, you say? The sunken chest, or?
Yes, the sunken chest in the upper chest is present in the postoperative time. It's only remodeling the lower chest. As you can see there, the patient is happy. In that time, we are happy. And then when we retire the implant and the next, and we study again the MRI, the cardiac compressions continue.
Oh.
It's not a good result. And then we start to change.
2018, right?
Yes, it's 13 to 18. But all the change in this patient is 3, 4, or 5 years after the surgery, because the patient is with the implant 2.5 to 3 years postoperative years. And when we saw that, we start to change and put more implants and start with total chest remodeling. It's a new concept. It's very important to treatment this kind of pathology, because the aim of the treatment is not only the reshape the chest. It's important the cardiac compress. Maybe the next is the revolution is about that.
Cardiac decompression and complete chest wall remodeling. This is the revolution.
Yes.
Okay.
Yes. One is by the hand to the other.
Yes.
You know, it's impossible.
Achieve one.
Yes, but if you don't do it total chest remodeling, the cardiac decompress is not possible.
Okay.
This kind of surgery we performed 10 years ago today. In the left, is the photograph of the patient and the MRI before the surgery, and in down is after surgery, the results. And after bar removal, study again with MRI and echocardiography, and the results are good. In our patients, 80% of the patients, they had zero compress, and the other improved type 2 to type 1, but all the patients' echocardiography is normal in the postoperative time at this time. How we perform the total chest remodeling? Because we use the 3D planning or 3D reconstruction of the chest, and the implant is customized for that patient. It's very important.
The yellow line, it will be the implant, right?
Yes. It's
So
the shape of the implant is for that patient.
So we can assume that sternum will be raised up, elevate to the yellow line.
Yes.
At the end of the surgery.
It's very important in the asymmetric pectus, because it's most common asymmetric pectus than symmetric. In our series, 79% of our patients, they have sternal rotation. And when the patient has sternal rotation, the pectus are asymmetric pectus. It's most common than symmetric. In that patient is the other talk, but it's about only surgical strategy. They are different between the shape of the implants. It's very important to do the total chest remodeling and symmetrical remodeling.
And in the operating room, you have a custom-made bar for the anatomy of that patient. So you are not bending anything manual.
Anything, okay. and never touch again the implants. When we put the implants and turn around, the implant is perfect for that patient because it's for him.
Custom-made, yeah.
Yes.
Perfect.
And we put the implants wherever the patient needs it. It's parallel, cross, is different in different anatomy of the patients.
And how many bridges do you have? Because I see 2, 4, a lot. Not always 2.
No, at this time, in the beginning, we use bridge for parallel, curve and rect. We have 3 kind of bridge, and now only one is for all, because it's useful for all the position of the implant. It's very useful at this moment. The bridge is changing. This is the second generation about the bridge at this time.
Oh, interesting.
And this is the other problem. The 0.8 to 33% of the patient present bar displacement is not uncommon, but it's very important complication, because some patients had a serious complication about bar displacement, because the aorta is there, the cava is there, the heart is there. Is published more than is not uncommon complication. For this reason, we never use again stabilizers. We use bridge, only bridge, and U-block bridge. As you can see here in the video, the bridge block the implants and never displacement the implant. It's very safety today.
So the bridge reduced the 33% of displacement rate to 0 now.
0. We perform today 1,000 88 patients with breach, 0 displacement.
And that's why you always put at least 2 bars, because you cannot put a breach in one.
Yes.
Okay, very interesting. I can see why there are so many myths around the patients about this surgery, because it was too many risks in the past, or maybe in the actual time in another centers, but Clínica Pectus has it dominated, I think.
The breach?
Yeah, that problem. The Clínica Pectus doesn't have it anymore, but
No, we don't have it.
yeah.
We have a patient with the other clinic with this kind of complication. It's not good. We publish our experience. We teach our experience about that. It's very important thing. It's not a detail. It's very important thing about the surgery.
I can imagine that it's really difficult make another surgery in a patient with implants that you don't put that
Yes.
made in another clinic. So, but we
Yes.
receive a lot of that patients and a lot of doctors that came to learn this surgical approach.
In our clinic?
Yes.
All year.
Yeah.
We have doctors for all the world come with us to learn and stay 1 month, 2 months, 3 months, no more today. In the other years, they stay with us for 6 months, but no more, because there are a lot of doctors come with us. It's important to learn in 1 or 2 months.
Okay. And I can see Cryoanalgesia. This is for pain management.
Okay, Dr. Facundo is continuing.
Okay, I leave Dr. Gastón to rest a little bit, okay? In the past, as we know, the Nuss procedure was a very painful procedure. And we also have advances in pain management. We perform cryoanalgesia for more than 10 years here in our clinic. And to understand how it works, the mechanism may be easy to understand. We temporarily freeze intercostal nerves with a specialized probe, okay? This doesn't kill the nerve, it just like takes out the conduction to the brain. So the patient feels better in the postoperative time. And we have published about this also. We had reduced the use of opioids, and the stay of our patients today is 1.4 days. Another thing that is important is not that only the first postoperative days are better, but the patients during the first whole month feel better, okay? And that is very important because for the success of this surgery, we need the patients to move, okay? We have an important kinesiologist program, so the patients need to really move and to recuperate, okay? So cryoanalgesia gives us a benefit not only for first days, but also in that period of time.
Wait, but when do you perform cryoanalgesia?
Okay, we have we have 2 types of ways of applying cryoanalgesia, okay? For patients that are generally most of our patients, we applied in the same procedure in the total chest remodeling, okay? It's one before the external elevation, we perform cryoanalgesia with this equipment you're seeing there. This has a long type of probe, okay? And we applied in the intercostal spaces. Yes, thoracoscopically, okay? That is the most common way we apply cryoanalgesia. In some selected patients, we can also perform it some days before the surgery as a percutaneous way. But we leave this to other type of patients we have who are maybe sometimes more complex because they already had previous thoracic surgery and other type of problems, okay? Generally, within one procedure, one anesthesia, only with that, we can perform not only the procedure, but also the cryoanalgesia for the patient.
And you say that you reduce the hospital days
Yes.
without cryoanalgesia. What is the normal?
Okay. For us, this is like a personal experience. The first time I saw a Pectus Excavatum more than 15 years ago in another hospital, the patient remained 15 days hospitalized with morphine, okay? And for me, that was like a crazy experience, okay? I felt this surgery is like a torture, okay?
Yeah,
now
15 days.
Yeah, 15 days with morphine, okay? And it was really a traumatic experience for both the doctors and the patients, okay? But that really changed from nowadays, okay? In our center, as I was saying, we only have 1.4 days of stay at the hospital, okay? So it's quite crazy, okay? If you
Maybe the next.
Yes, maybe I'll show you now. I'll just go around one more concept, Rocio, and we'll show you some of our patients, okay?
Yes.
And also for us, it's very important to bear in mind the psychological support and the physical therapy, okay, for the patient. All of our patients go through both experiences, let's say that way, okay? We have our psychologists here in Clínica Pectus, which prepare patients emotionally. They teach the difference between what's pressure and pain, and this is a very important aspect of this surgery because not many surgeries have this issue, okay? When we put the implants, the pressure applied from the chest to the implants creates a very disturbing way of feeling, which is pressure, okay? And pressure it's not the same treatment as we do with pain, okay? If you have pain, we give another type of treatment, okay? We can give another analgesic, okay? But generally pain, it goes away alone. So our psychological team, together with the physical therapy, help us with that process, okay? Also, psychological support lowers anxiety of the patient. And all patients before surgery go through a physical therapy, okay? We started breathing and postural correction. We ensure the muscles and the spine adapt to these new changes of the chest shape. Remember that this is not only just like popping up the hole the patient has. We need remodulation of the thorax and many times also of the spine too. We have to change everything. Okay, so the patient is going to have a lot of things to see, and it prevents also reverting the sunken posture in physical therapy. That's maybe something we put there, but really physical therapy is not about preventing to revert the sunken posture, but it helps the patients that are feeling like muscle contraction, okay, to have less pain and better posture in the first month, okay? So it's very important for the patients. They're also going to have this company of our psychologists and our physical therapy after surgery, of course, okay?
Perfect. And the active recovery, really important. As we see here.
Yeah, here we have some of our patients. We are a very big team, okay? So every member of our team wants to know how the patient is doing, how it's feeling, okay? So we are used to filming every patient, maybe just a little video of 1 minute, okay? So in the first postoperative day, okay, these patients you are seeing here are the first postoperative day. They are all performing exercises, and we test them how they're feeling the pressure, how they're feeling the pain, okay? And as we were saying, most of our patients in the first postoperative day, they can be discharged, okay? So we're really proud of our results with these patients, okay?
And we are seeing in the video the spirometer too for the breathing exercise.
Yeah, that's an important part of our kinesiologist aspect. Okay, they need to have the recovery not only of their movement, okay, but also of the lungs. We put the implants in the cage, and they need to expand the lungs, and they have it's a very important aspect to avoid complications. Okay.
Great. So now are we getting to the end? And before the answer all your questions, I need to clarify that if you want to have an appointment with us, with the doctors, it's a really easy journey because we have all planned and we receive international patients all the time. You have two steps. One initial virtual appointment with the doctor. It's really important that you bring the CT study and photos that we will ask, and they review your medical history and discuss the tailored treatment plan and tell exactly what you need to expect, all in that appointment if you have all the studies. And then we plan all the travel and treatment for you. And we just made a state-of-art facility here in Buenos Aires with the Airbnb and the tickets. We pick you up in the apartment the airport, just for you to have the best experience as possible. The doctors has their own part, the surgery, and we have another part for you to be right here with us in the Clínica. You can send me an email in that address, and I be in contact with you. You can, and now the funniest part, I think, the question. We receive a lot of questions in the Google form.
Mm-hmm.
So I assume that people will see the record next.
Mm-hmm.
Oh, what is that, Dr. Giacosa? I see a book, and it's the same book that is behind the doctor.
Here,
Yes, what is that?
this is our book. It's published the last year. It's about only Pectus. We write and edit this book with Marcelo Martinez Ferro and Manuel Lopez and me. And our clinic, all of our team is writing in that book 87 chapters about Pectus pathology. It's very nice.
Mm-hmm.
It's a lot of work.
Yeah, I can imagine. Pectus from A to S. So I think all about Pectus.
All about Pectus.
Yeah.
Mm-hmm.
Let's continue, please. Because we have like 9 questions. And this is Bree Sauer is in this meeting right now. She asked the same from the chat, so we can talk about this situation. I think it's a woman, 36 years old. She say, do I need surgery? Because she has a lot of symptoms.
Okay. Yeah, it's a 36-year-old woman. She already has a CT. Okay, in this CT, she has a severe pectus with an impact in the right atricle and the right ventricle. Okay, she had also performed an echocardiogram, which shows a trivial atrial split valve regurgitation. As she experiences bouts of severe air hunger that lasts for months, but that can pretty much recover and be good for some years. Okay, the air hunger is debilitating and simply the worst. I was unaware of how severe the Pectus Excavatum was, as I could only see tent below my breast. Okay, and for this situation, she asked us if she needs surgery.
Exercise psychologist.
Mm-hmm.
Yes.
Okay, so she has a healthy lifestyle.
Yes, this situation is very common. It's unbelievable, but it's common because in female it's not easy to perform the diagnosis of Pectus Excavatum. And in the most of the patient is not important female or male. When that patient didn't have symptoms in young age, maybe in adolescence, and then when the thorax is more rigid than more than 18 years old, start the symptoms. Maybe in some patients start at 20, but a lot of patients start more than 30 years old. And
She says symptoms since age of 25.
yes, it's common because the thorax is more rigid at that age. And then start with the all kind of studies. It's more common in female because when we see the female is not easy to perform the diagnosis. And then start with all the treatment, maybe for all cardiac disease, like arrhythmia or palpitations or wherever the patient feel. And then when the other treatment is not function, start the diagnosis of the pectus. You know, let me show one patient. It's the same situation. This is the 3D printed of this patient. Can I explain you? She's a woman and she's a doctor. She has 55 years old and she has atrium fibrillation, and she was treated in the first time with medication and in the second time with catheters for cryoablation of cardiac ablation, and they don't function. The patient is regular, the results. And then the last year, at 55 years old, he present in 3 times cardiac disease, and she need entry to the coronarium unit, and she present the pericardial effusion, you know. And she lives in another state, and the doctor called us the last year and asked us if she needs the surgery. And her chest, this is a 3D printed, but the problem is the skin of this patient is in this situation. When we saw the patient is not easy to perform the diagnosis of the pectus. But when we take out the heart, and this is the heart of that patient, and this is the atrium, is compressed a lot. And we performed the surgery the last year, maybe 8 months ago, and she's very well, and she never present again atrium fibrillation. And this is common. This question is very common. The parents of our patients consult to their child, and then consult for day and say, I'm tired, I'm very tired at 40 years old. It's common.
Okay. And it gets worse with age, maybe? It will
Yes.
get worse?
Yes, it's possible. Okay. If the patient has cardiac compression, all their life is compensated. You know, if they see the heart in really time, the heart is in the one side to the other side, with the sternum is compressed, and the heart movement in this way. When we operate the patient, we see, and the cardiologist is in the OR and perform the transesophageal echocardiography, and they see when I see transthoracic. We see about optic and the cardiology under the esophagus. And then we put up the sternum and perform the sternal elevation, everything change it. It's very common. She asked something about the cardiologist. She right?
Yeah, but maybe it's better to see her in a consultation first.
Okay. It's very good question, and it's common situation.
Yes.
And
it's a really common situation also that another doctors just dismiss the symptoms because I think, tell me if I'm right, Pectus is like a new research right now, right?
Yes, cardiopectus is a new topic in cardiology
area.
Yes. The last year we did the first cardiopectus symposium here in Argentina, International Cardiopectus Meet, and in that time we were 160 people, and 2 weeks later there are here in Buenos Aires the cardiologists meeting, all the cardiologists, and there are 9,000 people. You know, is a little specialty in that big specialty is cardiology.
Yeah. The cardiopectus in cardiology, yes.
Yes.
So here also, this patient is telling us she has a normal spirometry, okay?
It's normal.
And for us, this most common finding, okay? As we have already seen, if you remember the types of pectus we have, generally only the plateau patient, the flat chest, have some changes in the spirometry. Most patients do not have changes in the spirometry. Okay, so that's a normal finding for a Pectus Excavatum patient that has also a cardiac compression. And for us, as we were telling, she performs a little questionnaire if the pros of surgery outweigh the cons. And I believe for us, of course, the pros outweighs the cons. Okay, this is a life-changing surgery. Okay, we have a lot of patients at our clinic.
Sorry, in this kind of patients?
Yes.
It's very huge surgery. It's not that surgery at 17 years old. Mm-hmm. This is very important. It's not for all surgeons. It's very huge because maybe they needed hybrid procedure. The thorax is very rigid and maybe they need cut some cartilage to do it the chest more flexibility, you know, for many reasons. It's about details of the surgery, but they need hammock, they need the other things to good results in this kind of patient. It's different to Nuss procedure or to new Nuss procedure at 17, 18 years old or 12 or 9.
Yes.
But it's necessary if all the other situation is study and don't work with medication, and she has Pectus Excavatum, maybe she needs the surgery.
Yeah. Yes. Another question would be, how often do people with bad curvature, a Haller index of 4.2, have later in life discovery of this problem? How does something like this go unnoticed for so long? Okay. So we already talked about this in the last last patient. Maybe I can say that as we have seen, okay, the female patients are harder to recognize, okay, and also big patients, okay. The most common patients when they are adolescents are thin patients, okay. So Pectus is quite easy many times to be noticed, okay. But as we go by, this is not so easy, okay. And maybe this third question is: have you ever seen a case where Pectus excavatum caused gastrointestinal symptoms like constipation, reflux, or abdominal pain?
With reflux and abdominal pain, yes. With constipation, not, because it's not common. But if is presented some patients with flat chest, there are liver compress and maybe esophagus compress in the abdominal cavity, and maybe the gastric compress too. And maybe in that patient present this kind of symptoms, and after the surgery improve that symptoms. Yes.
Okay, fourth question, that is one of the most common questions we have, of course, is what can go wrong in a surgery? Okay, I'll start with the question, and generally, as we have seen, okay, the surgery has become very safe surgery. Okay, we have in 100% of our patients, we elevate the sternum. 100% of our patients have the bridges, and most of our patients have cryo. So everything is performed in a safe environment with a team that is well prepared. So we don't have problems within the surgery. Generally, what we experience are two types of problems. One is pleural effusion. Generally, pleural effusion starts or appears within more than a week, maybe 10 days, 15 days, okay? And generally, it's not a problem for us. Some other surgeons believe it's common in other patients, so they don't refer it even as a complication. And in that cases, not all the patients need to have an extra procedure, okay? Maybe we have only, and we are studying it, it's going to be a publication also, 10% of our patients have a pleural effusion. Only 5% of those patients need to be extracted, okay, that pleural effusion. And most of those pleural effusions are not infections, okay? It's just different changes. The thorax suffers impression, okay? So that is the first complication, let's say. And the second complication is the infection, okay? We have only a 0.8% of patients which have infection, okay? That are the two main problems, and they don't arise during the surgical procedure, okay? And I leave this question to Dr. Bellía. What is the success rate of surgery?
It's very higher at this time. Yes, it's very higher because we perform the total chest remodeling. If more to perform cardiac decompress, we need more than 19% of the total chest, of the chest remodeling, you know? If the patient has a huge malformation, we perform the remodeling more than 90% to do the cardiac decompression. In this time, we use, with this technique, the success is high. Yes.
Yes. The sixth question is, what are the pregnancy risks if you have severe Pectus excavatum? Okay, this is a very frequent question also patients ask. And we always, in patients that are looking, okay, to get pregnant, we always advise the surgery to be done before. Okay, there are the patients during pregnancy which may have appear symptoms. Okay, and within the pregnancy, of course, during the third trimester is worse. Okay, because of the less cavity you're going to have. Okay, so we always advise the surgery first. Okay,
There are published patients with pregnancy with implants
yes.
without problem. It's not common, but in the literature is published around 50 patients pregnant with implants without problems about that. The other question maybe appears down is the successful relation with the age. Maybe it is one of the questions. Yes, in the other time, not in this time. If you ask me that question 9 or 10 years ago, in that time, maybe 12, we don't want to perform the surgery in that patients because the technology, it was different at that time. It's not like this time. In this time, we have a lot of device and help us to perform a good surgery today. It's not the same procedure with teenagers, adolescents, and adults. It's totally different. The incisions are the same incision, but inside are different tips to perform the safety surgery and successful results. Yes.
Okay, there's another question. Does Nuss procedure increase rib flare? Okay, so this question, simple answer is no. Okay, as we have been seeing, we perform a total chest remodeling. Okay, many patients come to us and they are worried about their rib flares more than the pectus. Sometimes it's, for us, it's like kind of crazy. But as we were saying, the patients in the same act, we perform the total chest remodeling, and we have some tips and some tricks. Okay, for the rib flares to become normal. Okay, that's very important. We have sometimes we put special sutures. Okay. That keep the rib flares down. Okay, so no, we don't increase it.
Sorry, Facu. We use in that patient in 50% of our patient we use some string. In 50% of our patient we use suture is magic string or flare buster to correct any part of the chest is carinatum or maybe the flare buster. We use this kind of suture to improve that point of the chest. For this reason, we use the word total chest remodeling.
Bro, do you have any questions from the audience? Maybe we have also some more, but if you want.
No, Brie says, in theory, could pregnancy help with flexibility of chest wall with implants? I don't think if I get it. Could pregnancy help with flexibility of chest wall?
No, it's not difference between. It's not a problem. The rigidity of the pregnancy itself. Okay, we advise the patient to perform the Nuss procedure before to warrant so they don't have symptoms during the pregnancy. Okay, but not because of the flexibility of the chest.
Okay, that's it.
Okay.
I think we have 2 more questions.
Yeah.
In the presentation.
Mm-hmm.
I can.
So
read
there's one that it says, do you often see carry malformation and connective tissue disorders together with pectus? In this question, chiari malformation is not a common association with Pectus excavatum. We do not see it. But connective tissue disorders, yes, it's a very frequent association. We have many patients.
The most common is Marfan syndrome.
Okay, and we treat them. Okay, they need their treatment as any other patient, as any other Pectus. Okay, and question number 9: the surgeon said my son is one of his thinnest patients. Can being skinny cause problems with the Nuss procedure? And maybe here, just like a joke, if we put all of our patients, your son probably won't be the thinnest, okay? Because Pectus patients really are very thin most of the times, okay? So that's not a problem with thoracic remodelation, okay? And maybe just one more question I have here. That is, can the Titanic...
Sorry, in that question, in the other question, in the first month, the patient is less the weight.
Yes, the weight.
Yes, because all the energy is put to recovery and the new tissue. It's common. The patient are very skinny, and the first month is down, and then start to go up.
Gain weight, yeah.
For postoperative months, we discharge completely about the exercise and see again the patient at year, and then at 2 years, and then 2.5 to 3 to bar removal, to prepare the bar removal. In adults, maybe 3 to 4.
Mm-hmm.
That is an interesting point. How many time after surgery they need to wait to come back to normal activities and exercise?
In the second month, start to running and swimming. Okay. In the third month, it's and the second month maybe start to gym with weight. And in the fourth month, start maybe in our country more. A lot of patients play rugby. They start rugby at 4 months.
Okay, so 4 months to the final discharge, we can say. Mm-hmm. Okay. And the last question?
There's a final question that says, can the titanium rods be kept in permanently? I have a muscular dystrophy, so my Pectus excavatum is from muscular weakness, okay? I felt that if we remove the rods, okay, the Pectus will have a recurrence, okay? That's maybe the case. So the patient asks us if we can leave the rods or which are the consequences of leaving them, okay? Generally, as we were saying, we remove the implants 2 or 3 years after the procedure, okay? We have seen in some patients that stop going to the doctors from other clinics, patients that had the implants maybe 10 years, okay? And we have seen complications. Sometimes the implants, these were implants that were put in the past many times, okay? So they have, for example, a stabilizer, and sometimes the stabilizers go into the thorax. Some of the patients in time will have some pain also, maybe. And a concern, as here in the question they put it, is about CPR, okay? We try to remove the implants, okay? Because some patients may need CPR in the future. You can perform CPR in patients with Pectus excavatum, doing it from the back, okay? But maybe it's not as easy or as helpful as doing it from the chest, okay? So we always analyze every case, okay? This question comes from a very specific case. We should see and talk with him, what are his expectations and everything, and we'll see what's, or we'll talk what's better for him, okay?
We have patients like that, not like muscular weakness, but yes, in redo surgery. When the patient has resection surgery in the past and they don't have cartilage, they need external implant and internal implant. And then we take out the internal, and external is all life there in titanium without problem. It's not
Okay.
common, but we have some patients in this situation.
Okay, thank you
Okay.
very much. This is our whole team. As you can see, we're a lot, not only of surgeons, we have our psychologists, we have our kinesiologists, okay, secretaries that work with us. We have plastic surgeons, okay, we have cardiologists, so anesthesiologists.
Secretary, very important for us.
Always.
Communication.
Communication, okay. They help us with everything.
Okay, thank you very much for connect to this meeting and for the people who is going to see this in the recorder video that I will upload to YouTube and send the link. So thank you and see you in another opportunity.
Thank
Bye-bye.
you. Bye-bye.
Thank you very much.
Bye.